Welcome to PRISM Rounds, the audio journal club, where we break down one study at a time for ICU, ED, and pulmonary/critical care teams, including physicians, trainees, nurses, pharmacists, and respiratory therapists. Each episode is designed for busy clinicians who want to understand not only the headline result, but also the clinical question, study design, key findings, limitations, and bedside relevance. The goal is to make new evidence easier to digest and more useful for real-world practice. Whether you are on service preparing for rounds, teaching learners, or simply trying to stay current. I originally started making these episodes to support my own learning and review. I am sharing them publicly in case they are helpful to other clinicians and learners who are trying to keep up with the growing critical care and pulmonary literature. Everything you hear is for educational purposes only and should not be taken as medical advice. Clinical decisions should always be made in the context of the individual patient, local practice standards, and the judgment of the treating clinical team.
Welcome to the deep dive. If you are an intensivist, an ICU hospitalist, an infectious disease clinician, a bedside nurse, or, maybe part of a vascular access team, you live and breathe central lines.
Oh, absolutely. The central venous access device, or CVAD, is it is the absolute lifeline of the modern intensive care unit.
Right. We're talking about up to 80% of adult critical care patients requiring one at some point.
Yeah, whether it's for vasopressors, broad-spectrum antibiotics, continuous renal replacement therapy, or total parenteral nutrition, they are just everywhere.
Exactly. And today, our mission is to really analyze this recently published pragmatic multicenter Canadian trial that honestly it fundamentally questions our daily line maintenance habits.
It really does. We are going to look at the data to determine whether switching out standard saline for 4% tetrasodium EDTA as a locking solution for inactive lumens actually reduces catheter complications in adult ICU patients.
Which is such a critical evaluation to make, right? Because, as pulmonary and critical care physicians, we dedicate an enormous amount of our cognitive bandwidth to insertion.
Oh, totally. We obsess over the insertion bundles.
We really do. We mandate ultrasound guidance, strict chlorhexidine skin antisepsis, the maximal sterile barrier precautions.
Right. We treat the insertion like a major surgical event, as we should.
As we should. Yet once that CVAD is sutured in place, the broader critical care culture just it tends to overlook the physical environment inside those inactive lumens between medication administrations.
Yeah, we just ignore the unused lumens sitting locked between accesses.
Yeah.
And the observational data on those inactive lumens is actually highly revealing.
It is. Research indicates that an unused lumen remains locked for an average of 22.4% of a catheter's lifespan over a typical 7-day period.
And during those idle hours, biology just aggressively takes over.
Yeah.
Microbiological analyses consistently demonstrate that biofilm forms in 100% of removed central lines.
Wait, 100%?
100%. And that is entirely independent of whether the patient actually exhibited clinical signs of a bloodstream infection.
Wow. It's like building this massive multi-lane high-speed highway, which is our central line.
Right.
And we obsess over the on-ramp, making sure it's perfectly paved and clean. But then we just completely ignore the closed lanes and we allow potholes and weeds to just take over and ruin the whole road.
That is a perfect analogy. You are letting the potholes, which in this case are thrombosis, and the weeds, which are the biofilms, just completely take over.
So how does that biofilm actually form? Because I feel like we just say biofilm and move on.
Yeah, the pathophysiology is what makes line maintenance so difficult. We do casually call them biological weeds, but that grossly underestimates the microbiology here.
Right, it's way more complex.
Exactly. When planktonic bacteria enter a catheter, they transition into a sessile state, and they begin constructing this highly fortified biological bunker.
A bunker made of the extracellular polymeric substance, right? The EPS matrix.
Yes, the EPS matrix. And this matrix adheres fiercely to the internal polymer of the CVAD.
And it shields them.
It physically shields the microorganisms from systemic antibiotics, it isolates them from the host's immune system, and it even protects them from the fluid shear stress of our standard flushing.
So when we flush with saline, we aren't really doing anything to that bunker.
Not at all. Once that fortified bunker is established, the bacteria actually engage in quorum sensing, altering their gene expression to become exponentially more resilient.
Wow.
The standard practice of flushing an inactive lumen with normal saline does absolutely nothing to compromise the structural integrity of that EPS matrix.
Normal saline basically just washes right over the roof of the bunker.
Precisely. The biofilm continues to grow, it alters the local coagulation cascade by promoting fibrin deposition, and eventually, well, it causes a complete lumen occlusion.
And that mechanism of failure is exactly why investigators turn to 4% tetrasodium EDTA, which we will just refer to as t-EDTA for the rest of this deep dive.
Yes. So since normal saline or heparin and, 4% citrate for dialysis clearly aren't stopping these biofilms, we need to look at changing the locking fluid itself.
Right. So what was the actual intervention here?
The intervention in this trial involves ICU nurses instilling 2.5 milliliters of 4% t-EDTA into any inactive CVAD lumens.
And the control group?
They receive the standard of care,
Yeah.
meaning normal saline for the vast majority of central lines and 4% citrate specifically for hemodialysis catheters.
Okay, so let's talk about the chemistry behind t-EDTA because it's actually really elegant. It is a high-affinity metal chelator.
It is. You can visualize it as this little molecular claw that just systematically strips divalent cations out of the local environment inside the lumen.
Right, it specifically targets calcium, magnesium, and iron.
Exactly. And those bacteria building their EPS matrix, they desperately require calcium and magnesium to cross-link the polymers of their protective bunker.
So without those specific minerals, the structural integrity of the biofilm simply collapses.
Boom. By starving the bacteria of those structural cations, t-EDTA acts as a highly potent antibiofilm and antimicrobial agent.
And it does something else too, right, with the calcium?
Yeah, the chelation of calcium serves a dual purpose. Because calcium acts as factor 4 in the human coagulation cascade, binding it effectively halts the formation of thrombin and fibrin.
Oh, so you are simultaneously deploying a localized anticoagulant and an antibiofilm agent directly at the site of vulnerability.
Exactly. It's a 2-for-1.
But, I mean, a chemical that kills biofilm in a petri dish is great. Translating that biological theory into a high-quality clinical trial in the middle of a modern, chaotic ICU is a completely different challenge.
Oh, it is a massive logistical feat. How do you even test this in the real world?
Well, the investigators designed a pragmatic, triple-blind, multicenter, cluster-randomized crossover trial.
That is a mouthful.
It is a mouthful. They executed this across 6 Canadian hospitals, deliberately including both community and academic ICUs to ensure broad applicability.
And the population was adult patients in the ICU who had a CVAD with at least one unused lumen.
Right. They ultimately analyzed 1,468 patients. 696 received the t-EDTA, and 772 received the standard control.
But the structural design of the trial, that really warrants careful attention. In a cluster-randomized crossover design, the individual patient is not randomized.
Right. Instead, the entire ICU acts as the randomization unit.
Exactly. A specific ICU utilized one locking strategy for a block of 3.5 months.
And then they took a break.
Yeah, following that phase, they initiated a 1-month washout period to allow the existing patient census to cycle out of the unit. Then the entire ICU crossed over to utilize the alternate locking strategy for another 3.5-month block.
See, from an epidemiological standpoint, cluster randomization always invites scrutiny, right? Because when you randomize at the unit level, you inherently risk masking patient-specific confounders that might skew the data.
Like what?
Like a localized outbreak of a specific pathogen in one unit, or a sudden shift in patient acuity during that 3-month block. I mean, the gold standard is usually randomizing patient by patient, bed by bed, concurrently. Why not just do that?
That is a fair pushback. But while patient-level randomization provides cleaner statistical isolation, it completely fails to account for the operational realities of critical care nursing.
You mean the chaos?
The absolute chaos.
Yeah.
We are practicing medicine amidst severe systemic nursing shortages. The cognitive load required to manage multiple critically ill patients is staggering.
That is very true.
If a trial design requires a bedside nurse to remember that, the PICC line in bed 3 requires an investigational t-EDTA syringe, while the central line in bed 4 requires a standard saline flush.
Oh, you are essentially guaranteeing protocol deviations and medication errors.
Exactly. The trial would end up measuring the limits of human memory rather than the efficacy of the chelating agent.
That makes total sense.
By assigning the entire unit to a single protocol, The investigators prioritized clinical pragmatism and external validity. You stock the supply rooms with one specific type of pre-filled syringe, you educate the entire nursing staff on one protocol, and the work so standardizes.
It mimics the actual real-world systemic implementation a hospital would face.
Precisely. Furthermore, the crossover design, where every unit eventually uses both strategies, helps control for those seasonal variations or unit-specific culture differences you mentioned.
Okay, so with the whole unit aligned, they captured a massive amount of data. They recorded nearly 20,000 individual locking events.
Wow.
So we can finally look at what happened to these central lines over time. The primary outcome they measured was a composite incidence rate.
Right, they wrapped together 3 distinct clinical failures: CVAD-associated bloodstream infection, catheter occlusion requiring the administration of alteplase, or catheter removal due to an unresolvable occlusion.
Grouping those 3 events into a composite outcome really reflects the clinical continuum of biofilm and thrombosis complications.
It does. And the final data showed the incidence rate of primary outcome events was 13.1 per 1,000 catheter days for the t-EDTA group.
Okay, and the control?
The control group experienced 19.9 events per 1,000 catheter days.
So 13.1 versus 19.9. That yields an adjusted rate ratio of 0.68 with a 95% confidence interval of 0.47 to 0.96 and a p-value of 0.03.
Statistically, that represents a significant reduction in overall catheter complications.
The absolute rate reduction was 5.1, and translating that to the bedside, the number needed to treat is roughly 20.
So for every 20 central lines managed with the t-EDTA protocol, the unit prevents one major complication composite event.
But unpacking a composite outcome always requires isolating the primary driver, right? What was actually moving the needle here?
Yeah, when you separate the 3 variables, the statistical signal was heavily dominated by a reduction in occlusions requiring alteplase.
Interesting.
The alteplase usage rate fell to 11.67 per 1,000 catheter days in the t-EDTA arm, compared to 17.73 per 1,000 catheter days in the control arm. That's a rate ratio of 0.66.
So this highlights a crucial divergence between the theory of dismantling a biofilm and the clinical reality of infection rates.
How so?
Well, if t-EDTA actively degrades the bacterial bunker, we should theoretically see a precipitous drop in central line-associated bloodstream infections, or CLABSI, right? The massive, expensive, deadly infections we worry about.
Right. But CLABSI was incredibly rare across the entire trial.
Exactly. The investigators recorded only 2 cases in the t-EDTA group and 3 cases in the control group.
You simply cannot derive meaningful statistical claims about infection reduction from 5 total events.
You can't.
And that low event rate really reflects the success of modern critical care. Over the past decade, rigorous adherence to insertion bundles and specialized vascular access teams has dramatically suppressed baseline CLABSI rates.
Right. When your baseline complication rate is hovering near 0, powering a clinical trial to demonstrate a further statistically significant reduction requires an astronomical sample size.
It is vital that you, as the listener, do not misinterpret this data as a definitive infection prevention victory. The trial just lacked the power to prove that.
The secondary outcomes really reinforce that limitation. There were no clear differences between the groups regarding catheter-associated venous thrombosis or colonization.
And more importantly, ICU mortality remained identical, sitting right around 21 to 23 per 1,000 catheter days for both arms.
The median ICU length of stay was also entirely unaffected, remaining at 5 to 6 days regardless of the locking fluid.
So let me just play devil's advocate for a second.
Go for it.
Wait, if this isn't saving lives and it isn't moving the needle on mortality or ICU length of stay, is this just an expensive way to save a few doses of alteplase?
That is the exact question every hospital administrator will ask. But the data firmly establishes that this is not a mortality trial. It is fundamentally a line maintenance and workflow trial.
Right. We have to evaluate the intervention through the lens of operational efficiency.
The practical clinical win here is the tangible reduction in blocked lines and the subsequent reduction in alteplase administration.
And to understand the value of that operational win, you really have to examine the systemic burden of a single blocked lumen.
It is a nightmare.
It is. When an infusion pump alarms for an occlusion, the clinical cascade is deeply disruptive. The bedside nurse must halt their workflow, physically assess the CVAD site, and attempt gentle aspiration and flushing.
And when that fails, which it often does,
they have to page the physician or advanced practice provider for an alteplase order. Then the pharmacy has to receive the order, mix the thrombolytic, and deliver it to the unit.
Which takes time.
So much time. Then the nurse instills the alteplase, waits up to 2 hours for the drug to break down the fibrin clot, and then attempts to aspirate the line again.
And the hidden cost of that entire process is the delay in patient care. During those 2 hours of troubleshooting, the patient is actively experiencing delays in receiving vital medications, whether that is a scheduled dose of piperacillin tazobactam, a continuous infusion of sedation, or their parenteral nutrition.
Plus, alteplase itself only targets the fibrin clot. It does absolutely nothing to clear the underlying bacterial biofilm matrix that likely triggered the coagulation cascade in the first place.
So preventing that entire sequence of events by utilizing a prophylactic chelating lock is a massive operational victory for nursing workflow.
It reclaims hours of nursing time in the middle of a worldwide nursing shortage.
But the data clearly shows that reclaiming that time requires strict protocol adherence.
Ah, yes. The adherence data is fascinating.
The investigators conducted a subgroup analysis examining how consistently the study drug was actually utilized. For patients who received the assigned locking fluid for at least 80% of their required locking events, the effect was robust, showing a rate ratio of 0.66.
But when adherence dropped below that 80% threshold, the statistical benefit basically vanished. Rate ratio of 0.88, not significant.
That 80% threshold really underscores the relentless nature of biofilm formation.
It does. If a unit consistently disrupts the EPS matrix with t-EDTA, planktonic bacteria cannot establish a permanent foothold on the polymer.
But in a busy ICU, doses get missed.
Right. A patient travels to radiology, or a line is accessed during an emergency, and the nurse flushes with saline out of habit.
And if you provide the bacteria with a 24 to 48-hour window free of chelation, they will rapidly cross-link their calcium polymers and mature that biofilm.
And once that bunker is fully structured, intermittent applications of t-EDTA are insufficient to clear it. Consistent, daily degradation is required.
We also need to examine the hemodialysis subgroup, which provided this really insightful physiological contrast.
Yes, the trial noted that the hemodialysis lines did not demonstrate the same reduction in complications when locked with t-EDTA.
Which might initially seem contradictory, but it aligns perfectly when we look at the control fluid used for those specific catheters.
Right, because the control arm for hemodialysis catheters utilized 4% citrate, and citrate is itself a highly effective calcium chelator, frequently used for regional anticoagulation in continuous renal replacement therapy.
So the trial was essentially comparing one potent chelator against another potent chelator within that specific subgroup.
It logically follows that t-EDTA would fail to show dramatic superiority when the baseline standard of care is already actively stripping calcium from the local environment.
Yeah, that is a very high bar to clear. We should also touch on the safety profile, which is paramount when introducing a new chemical into vascular access.
Oh, absolutely. The investigators reported 0 study-related adverse events, 0 serious adverse events, and specifically 0 cases of systemic hypocalcemia.
That last point is crucial given the drug's mechanism. Instilling 2.5 milliliters of a calcium binding agent directly into a central line did not meaningfully impact systemic serum calcium levels.
Which is great. The pristine safety profile is very reassuring, but it is entirely dependent on meticulous nursing technique.
Right. Translating this trial to the bedside tomorrow morning involves navigating some significant systemic hurdles.
The most prominent barrier is the required aspiration procedure. Because 4% t-EDTA is an active pharmacological agent, it cannot simply be flushed forward into the patient's systemic circulation like normal saline.
Exactly. The clinician must manually aspirate the locking solution out of the lumen and discard it prior to reaccessing the line for medication delivery.
And that requirement demands a complete dismantling of the deeply ingrained push-pause saline flush muscle memory that literally every critical care nurse relies upon.
It is pure muscle memory at this point.
Overcoming that habit requires comprehensive, unit-wide nursing education campaigns. Furthermore, adoption requires robust pharmacy support.
Yeah, the pharmacy department must manage the procurement, stocking, and dispensing of these specialized pre-filled syringes.
And your hospital's pharmacy and therapeutics committee, along with the value analysis team, will require a rigorous health economics review.
They must weigh the upfront unit cost of stocking t-EDTA syringes against the downstream financial savings of purchasing less alteplase and the operational value of recovered nursing hours.
They will also need to review local policies regarding compatibility with existing dialysis protocols, ensuring clear communication with the nephrology team before any changes are made to hemodialysis catheter maintenance.
But the trial provides the data to initiate those administrative discussions, particularly for populations highlighted in the subgroup analyses.
Like patients with prolonged catheter durations exceeding 7 days, or those with high-risk access sites like femoral lines, where anatomical location makes site maintenance notoriously difficult.
Right. So to synthesize the entirety of this trial for the clinicians evaluating their unit policies, we arrive at the core takeaway.
And that bottom line is this. 4% tetrasodium EDTA did not transform ICU outcomes, but it did appear to reduce the everyday nuisance and safety issue of occluded central lines.
And for bedside teams, that may matter.
It absolutely matters when you are trying to manage multiple decompensating patients and a lining just goes down.
Oh, there is nothing worse. But looking beyond this specific trial, the underlying biology of biofilms presents a really intriguing clinical horizon.
How so?
Well, currently, critical care utilizes a monolithic approach to line maintenance. We use the same fluid for almost every line, regardless of the patient.
Right, saline for everyone.
Exactly. However, as critical care evolves toward precision medicine, it raises a compelling question. If biofilm forms in 100% of unused catheters, are we approaching an era in critical care where leaving a central line locked with basic saline will be viewed as archaic?
Oh, wow. That is a fascinating thought. If we wouldn't leave a surgical wound undressed, why do we leave the inside of our most vital vascular highways unmedicated?
Right. Will we eventually abandon one-size-fits-all locking solutions entirely? Imagine a future where we tailor the chemical lock to the specific synthetic polymer of the catheter being inserted.
Or even customize the fluid based on a rapid genomic analysis of the patient's unique skin flora microbiome.
Exactly. As our understanding of the biofilm matrix deepens, our interventions will inevitably have to become far more targeted than basic saline.
Active chemical maintenance might soon become as standard as hand hygiene. It is definitely an evolving space to watch closely.
Something for all of you to ponder on your next shift. Thanks for joining us on this deep dive. Stay curious, and we will see you next time.
Thank you for spending your time with PRISM Rounds. If this episode helped you think through the paper or offered something practical for the bedside, I'd be grateful if you'd like, follow/subscribe, and share it with a colleague. It's the simplest way to help this resource reach other busy clinicians and learners. I'm also trying to make the podcast better with every episode. Please leave a comment with what you found most useful, what felt unclear or too long, and what topics or papers you'd like covered next. If there's anything I can do to improve, pacing, structure, level of detail, or audio quality, I genuinely welcome the feedback. Thanks again for listening, and take care. Educational use only. This is not medical advice.